So we are live now. Okay, so good evening to all respected faculty members and delegate who are present over here. I am Nilesh Darji from Corona Remedies. Welcomes you all in this Core Connect virtual webinar on the topic of induction of labor and clinical experience with dinoprostol vaginal insert. So today we have gathered to explore the vital aspect of obstetrics, where we are going to deepen the knowledge and understanding about induction of labor, and also we are going to see various methods of induction of labor. And out of those methods, which is the appropriate or suitable method which can provide the best safety profile for the mother as well as baby, that also we are going to see in this live webinar. So without wasting too much of time, I'm going to start this webinar with our digital live clamping ceremony. So let's start it. So thank you so much for your patience. Uh, Now I will introduce our scientific coordinator, who is Dr. Amit Bhargav. So Dr. Amit Bhargav sir is currently head of Medical Corona Remedies Private Limited. Sir is family physician in Ahmedabad, director of HEART of Medicine, ex-board member, medical faculty MUHS. Sir has done his education, means MBBS and MD, both from NAMC New Delhi, and also Sir has very vast experience of 36 years, 1 year in teaching, 2 year in research at NIH, Bethesda, USA, 2 year R&D and QA experience, 2 year IT industry, 10 year clinical practice experience, and 28 years in pharma, like Alembic, Alchem, Cadila, Elder, Glenmark, Lupin, and Sun Pharma. So we have with us Dr. Amit Bhargav sir, who are going to take a brief session on importance of clinical experience in current practice. So over to you, sir.
Thank you very much, Nilesh, and a very warm welcome to all the faculty members. I will not stand between you and the rest of the audience. I will just share my screen for a very short presentation on the importance of clinical experience, something which got overshadowed. What's happening in the sharing? There we are. Okay, share. Is it visible?
Yes, sir. Full screen is not.
Yeah, I'll just put it on slide. All right. Okay, so it's going to be a very short presentation. I promise not to take more than 5 to 7 minutes. So why do we hold these meetings when everybody knows everything? It's very simple. It's all about clinical practice, the new concept of clinical reasoning, and the importance of clinical experience. We all are familiar with this professional lifespan of doctors. We have all been students, we have acquired knowledge, become professionals, we practice, we become successful. And then comes a differentiating feature. Some people have exceptional clinical experiences because of which they start being proclaimed as experts. And we have three such experts here today. So there is a need for experts to share their exceptional clinical experiences, both locally and globally. So this is one reason why we at Corona have decided to hold such meetings. Second spectrum that we need to know is that the thing that we grew up on, the clinical evidence, evidence-based medicine and all these magical jargon words, it has now moved over to the concept of clinical reasoning for simple reasons that I will just highlight in a minute. This was one of the very first articles by a very renowned cardiologist. I mean, he was not one of those millions of cardiologists in the world. He was and is probably the head of Department of Cardiology at Mayo Clinics. He put it all together very nicely. These are all the different data elements that we rely on to deploy various drugs or devices in our practice. Guidelines, RCT, open observational studies, etc., etc. But that's not enough for practice. We need mechanistic reasoning that one patient sitting across the table, what is wrong in that particular patient is what I need to figure out. And on top of that, the value of clinical experience, something that can't be expedited, it just comes with time. So this entire gamut of mechanistic reasoning, all the data elements and the clinical experience is what the world refers to as clinical reasoning. And this is basically what is required for good clinical practice. So we know that all these data elements, they're accessible, they're in public domain, everybody reads it, PGs read it, everybody reads it, but it's all static information. Once published, that's it. And sometimes it is also contrived. It may not actually give us the real picture. But clinical experience, the experience of every clinician is unique. It is intrinsic to that individual. It is an integral part of his expert or her expertise, and it is dynamic. It is increasing with every year. But this is not very easily accessible to all of us, and the dissemination is also limited. And just to put the perspective of what exactly, how do we define? There's another article that was, this is actually a chapter of a book. It is a logical, systematic clinical process that guides clinical decision making. That is important. We are not into evidence-based decision making. This is clinical decision making, which is slightly different because it is particularly in unpredictable, emergent, and non-routine situations. Whereas in a clinical trial, everything is very categorical and very clear. And that leads to accurate information in judgment. So RCTs and guidelines, while they form the basis of a practice and we need to follow them, they are equipped to provide every solution in clinical practice. So clinical trial is a validated model with complete operational predictability. Everything is specified. That's why we make protocols. And limited outcomes applicability. Whatever happens in that clinical trial may not be applicable to that single patient sitting across the table because the clinical trial protocol has a lot of inclusion, exclusion, no comorbidity, no administration of drugs, etc. So, but clinical practice, as you see here, is the reality with operational unpredictability. I have no idea what that other patient that's going to come next is all about. And it requires considerable amount of customization by the treating physician. So there is the role of evidence, it forms the basis, but there is a very valuable role of experience which no clinical trial or guidelines can tell us. So the value of clinical experience in simple words is this. Clinical evidence plus clinical experience is what makes experts what they are. So thank you for this patient impatient. Now I will move over immediately to the main agenda of the new game-changing product, hopefully game-changing product. And we have three game-changing experts to enlighten all of us about it. And these are the three game-changing experts. Because of their experience, they have become experts. Dr. Sonam Bakshi, Dr. Meena Agarwal, and Dr. Asha Bakshi. And so without more ado, let me first introduce the first expert who will share her wisdom with all of us. Dr. Sonam Bakshi is consultant in Indore with Motherhood Hospital and Disha Fertility and Research. She has number of awards to her credit. Best paper 2013, 16. So multiple best papers. She's obviously into
Let's
research.
keep it short, sir.
Okay, sure. Member organizing team of SR and AICOG. She has been got a number of trainings in ultrasound, reproductive medicine, colonoscopy, and has number of publications for training. So with that, I will stop here. I will stop sharing this and hand it over to Dr. Sonam Bakshi. The forum is all yours, ma'am.
Hello, everyone. So I have this very interesting topic, why we need to induce the patient. So all this webinar is about inducing a patient, but we really need to know when and why do we need to induce the patient, and we need to select those patients we need to induce. So I'll just share my screen and one second. Is it?
Yeah, it's suitable.
1 second. So basically, it's about what is labor and when do we need to induce the labor. So introducing labor, it is regular effective uterine contractions which increases in frequency and leading to progressive dilatation of cervix and effacement. Sorry, I think it's not. Yeah. So basically, labor has 3 stages: first, second, third. We all are completely aware about. The first stage lasts for average 6 to 12 hours. The second one is for 30 minutes to 2 hours. The third one is for 5 minutes to 15 minutes. And the last one is after the expulsion. That is the fourth stage, 1 hour after that for the observation. So onset of labor can be because of the hormonal factors or can be because of some mechanical factors. The hormones which are secreted in the body for any of the reasons, say the progesterone withdrawal, estrogen, prostaglandins, oxytocin, or uterine distension for any reason, or softening of the cervix, effacement and ripening. Now, cervical ripening, which is very important for us right now, it has 2 phases. One is the slow phase and the other one is the rapid phase. So basically, in this, as we all know, the cervix is made up of collagen fibers. So the first phase, that is slow phase, requires reorganization of these collagen fibers, making it soft. And then comes the rapid phase, where these collagen is dissoluted by collagenase and elastase, and the cervix dilates and opens up. Next is the induction of labor. So basically, we need to know when and which patients do we need to induce. So we'll talk about this terminology in the whole, when we go forward. One is the cervical ripening. That is a prelude to the onset of labor when we prepare the cervix for dilatation. Then induction. Induction is artificial initiation of labor, and then the augmentation. Once the labor set in, we augment the process. We enhance the process by administration of oxytocin. Now, when you should have some indication for initiation of labor, you would not rather go about at 38 weeks, 39 weeks saying that, yes, we need to induce you now. So we need to induce the patient when there are some maternal or fetal risk associated with continuing that pregnancy. Why we need to induce? Because it reduces the chances of cesarean, post-term pregnancy, and pre-labor rupture of membrane. What would be the complications? Why we want to avoid these post-term pregnancy and cesarean deliveries? So with the post-term pregnancies, there are fetal heart abnormalities, meconium aspiration, there's increased neonatal morbidity, the baby size increases, and there's a lot of PPH, neonatal acidosis, chorioamnionitis, etc. With cesarean, there's thromboembolism, perinatal death, PPH, which might lead to hysterectomy, surgical complications, anesthetic complications, wound hematoma, and endometritis. Now, there are multiple indications of induction of labor. So WHO says if it is more than 40 weeks, more than 41 weeks, and the patient has not gone in labor or at PROM, RCOG says if there is PROM at more than 34 weeks, if there is other obstetric indication, or at more than 37 weeks, if the patient is term, if there's IUFD, if in cases of previous cesarean section, after informing all the risks and in a hospital setting, the ACOG says post-term pregnancy again, in PROM, fetal demise, abruption. There are certain contraindications as well. If the pregnancy is complicated, there's severe IUGR, some Doppler complications, abnormal Dopplers, the breech, fetal macrosomia. In these cases, we would rather not induce the patient and go for a direct section. Now, FOGSI has its own term of guidelines. According to the FOGSI, the Indian patients, they should be induced after 39 weeks. So absolute indication, according to FOGSI, is hypertensive disorders, preeclampsia, eclampsia, where they prefer inducing the patient at 37 weeks, but can do it before if there's any other indication. Patient suffering from any medical condition which is not controlled, then there's a fetal compromise, premature rupture of membranes, fetal demise, a chorioamnionitis. Prolonged pregnancy, actually, FOGSI recommends at 39 weeks in cases of low-risk pregnancy. Rest we have to discuss with the patient and form a birth plan. Then there are certain relative indications like risk of rapid labor, psychological indications, etc. These are the terminations I think everybody knows. Now, there are several studies about these induction of labor. So compared to expectant management, labor induction was associated with fewer perinatal deaths after 39 weeks. It is associated with lower risk of fetal death and admission to an ICU. It reduces the cesarean rate. There are several studies regarding the same. There are multiple factors which are implicated for the success of induction of labor. First, gestational age, of course, it should be more than 39 weeks. After that, only the induction has excellent result. Then the Bishop score. Nowadays, we follow a modified Bishop score, the FOGSI's modified Bishop score, which gives us a good, which helps us to actually explain the patient about their chances after induction. We should know the proper indication. The birth weight matters, the obstetric history, BMI of the patient, the parity, of course, if there is a multi-para patient, induction is quite successful, and the age. Now, cervical ripening definitely is essential and a prerequisite for successful induction of labor. In cases of favorable cervix, it is indicated definitely. In cases of unfavorable cervix, we should go for some artificial stimulation of cervical ripening. Maybe some pharmacological methods are available, and there are other mechanical methods which are also available. So this is the modified Bishop score, which are generally used before the induction of labor. There are few things we usually do in our practice. One, we need to have a proper informed consent. We should be thorough about the history, about the indication. We should discuss about the birth plan beforehand. The patient should know all their choices, and we offer induction after 39 weeks when the patient does not go in labor, or after 38 weeks if there is any particular indication like IUGR, hypertension, etc. Thank you.
Thank you very much, Dr.
Thank
Sonal.
you, Dr. Amit.
That was very short and sweet and to the point. Perfect. Thank you so much. I will just resume my
Sonal, can I ask you one question? Are you following this Bishop scoring in your day-to-day practice?
Yes, so we have this stamp. We have this big stamp which we put before the induction when we do a vaginal examination. So in our notes, we put this stamp which has a whole modified Bishop scoring. We calculate the Bishop score and we write the final score. And we try and do that after every vaginal examination so that we know how are we progressing with induction. And so we know how much the cervix has ripened, if it is not already ripened, and how are we progressing with the thing. And of course, it helps us to counsel the patients as well, that it might take long time, there are decreased chances or the chances are good, and it helps us also to know.
So I think it's very important. We have to really pay a lot of stress to Bishop score, because otherwise everything is vague. We ourselves don't know what is going on. Just clinical chal raha hai. But I think this is a very good way of documentation, and we all should follow Bishop scoring in our day-to-day practice when we are inducing the patients.
I just wanted to ask, Sonam, once you have induced, then what is the frequency of doing a PV examination?
So it
That is how
depends
you
on
will.
the patients. Usually we don't do it. We don't prefer doing it before 4 to 6 hours. If there are no pains, we don't do the PV examination, generally not even for 24 hours, unless we have to remove the
Insert.
insert. We don't do it. If the pains start, we do it after 4 hours. If the patient is complaining for pressure or any other symptom, or we have some fetal distress, then we can do it before that. Otherwise, we generally follow this way.
I think this is again very important, that unnecessary PV examinations are also to be
We
avoided.
don't let our juniors also do the PV examination without informing us.
Right. So, excellent. I think thank you, Dr.
Nice.
Asha, for
Well
bringing
done.
up this topic. This is in fact one of the classical examples of what we learn from clinical experience. You know, everything is not in the books and the guidelines.
Absolutely.
So, thank you very much for that.
Thank you.
Now I resume my pleasant duty of introducing the second expert based on experience, vast experience. This is done. Sorry, the laptop is a little slow. Okay, this. Second luminary for today, Dr. Neena Agarwal, consultant and HOD, and the fact that she's HOD itself is testimonial to her vast experience, on the basis of which we will learn a lot today. She is known and recognized for exceptional expertise in high risk and critical care obstetrics, not an easy game, special interest in laparoscopy, and has presented innumerable papers at national conferences. So with that experience behind her, ma'am, the forum is all yours. Let us learn from your wisdom.
How will I share my screen?
Just click on the share screen button, which is there in bottom, green color.
Yeah.
In the bottom line, number 4 from the left.
Yeah.
Share screen. Right. You've got the screen there.
Your Zoom page is visible, ma'am. Your presentation is
Is it visible?
No.
Yeah, it's visible. I mean, the Zoom screen is visible, not the PPT.
PowerPoint पे तूने PowerPoint minimize किया होगा ना, तो PowerPoint को press कर.
First stop this one. Stop
इसको हटा दे.
इसको हटा दो.
हाँ.
Stop sharing.
Stop share.
और क्रॉस में कर. हाँ. अब शेयर में जा वापस. शेयर स्क्रीन पे गई. क्या आया वहां पे?
व्हाइट बोर्ड और जूम.
नहीं, जूम नहीं आना चाहिए वहां तो.
जी आपका पावर पॉइंट पहले पीछे खोल लो. आपका जो
पावर पॉइंट तेरा नीचे है क्या? पावर पॉइंट तेरे इसमें नीचे की लाइन में पी होगा ना, तेरे स्क्रीन में सबसे नीचे पी होगा ना पावर पॉइंट. नहीं है तो फिर आपके
I
पास
will
होगा
share.
ना?
आप
हाँ,
कर
Yes.
दीजिए ना, हाँ,
Yes, yes, I will share. Just give
yeah,
me.
I will stop.
Yeah, that will be easy. Okay, there we go.
Yeah.
Just instruct me, ma'am. I will do the next slide. When is it visible, ma'am?
Now it is visible.
yeah.
So thank you, Sonal, for introducing the subject. It's very important, induction of labor. And now I will be discussing in short what are the methods available for induction of labor. So there are basically two groups. There is a non-pharmacological method of cervical ripening, and there are pharmacological methods of cervical ripening. So the non-pharmacological methods of cervical ripening were used in the olden days when all these newer methods were not available. The most common mechanical induction method just to stimulate the release of prostaglandin was membrane stripping and amniotomy. We know when patients used to come in our OPD at 40 plus weeks of gestation, we just used to do a gentle PV and do a nice sweeping of the membranes. And our professors used to teach us that this will cause the release of prostaglandin and she will go into labor. The other mechanical methods were use of balloon catheters, where the Foley's catheter were being used, a single balloon or a double balloon. Then there came an era of hygroscopic dilators, where there were laminaria tents were available, where we used to put them in the cervix, and they were hygroscopic. They would absorb water and the dilatation would start. And we also had the method of using extra amniotic salines. The main method of membrane stripping, which causes the separation of the chorioamniotic membrane from cervix. It was performed by inserting the examination finger through the internal os and rotating it around the cervix. This resulted in increase in the phospholipase A and prostaglandin F2 activity, causing dilatation and effacement of the cervix. Then the other method was amniotomy, which involved the perforation of the membranes at the time of pelvic examination, which we nowadays avoid. Next, please. The balloon catheters are inserted transcervically as the figure shows. The device is inserted through the undilated cervix in the extraamniotic fluid and then it is inflated. This inflated balloon actually applies pressure on the cervix, indirectly causing the release of prostaglandins and thus induction of labor. Then there were hygroscopic dilators, the mechanical devices that were placed in the lower uterine segment. And ultimately, all these methods resulted in induction of labor by view of releasing the prostaglandins. The mechanical methods are effective, but they have certain disadvantages, like there is a risk of infection, bleeding, premature rupture of membranes, risk of placental abruption. Sometimes they may cause umbilical cord prolapse, fetal injury, deceleration of the fetal heart rate. So all these years, there was always they were trying to find out a safe and effective method for induction of labor. So the mechanical methods of induction of labor are recommended in certain settings. The sweeping of membranes, as the RCOG recommends, it can be offered to women who come post-term. Balloon catheter is not used these days. Amniotomy is, of course, not done unless the patient goes into labor. Amniotomy is only done for acceleration of labor. The hygroscopic dilators are also not used these days. So now the pharmacological methods of cervical ripening, which are used most commonly in this era. They are prostaglandin E1, E2, and the inserts. So the prostaglandin available are PGE1 and PGE2. The PGE1 is the misoprostol tablet, and PGE2 is the dinoprostone, which comes in the gel form as well as in the insert form. So the role of endogenous prostaglandins in spontaneous cervical ripening has been known since years. The sources of prostaglandin during normal labor comes from the cervical fibroblasts and the amnion. These prostaglandins act synergistically with interleukins 8. They stimulate neutrophil influx from the blood vessels into the myometrium and cervix. These neutrophils are a source of collagenase, which is required for the collagen breakdown, and ultimately there is cervical ripening. The interleukin 8 maintains a sustained flow of neutrophils and perpetuates the inflammatory response. Also, these prostaglandins also cause myometrial contractility by increasing the intracellular flow of the calcium. So now when we compare PGE1 with PGE2, the PGE1 is a misoprostol prostaglandin E1, and PGE2 is the dinoprostone, which is available in the gel form as well as a long-acting insert. Next, please. The next. Initially, we used to use misoprostol tablets, which was not actually indicated initially. Initially, it was off-label use. But nowadays, the recommendations have come where we can use misoprostol tablet, which can be used intravaginally or sublingually. And the indication is for induction of labor with unfavorable cervix. The misoprostol tablet, now the guidelines have come, which can be used for induction of labor and cervical ripening. The next is the PGE2, which is most common, more widely used, more safe. It is available as 10 milligram insert, where the release rate is 0.3 milligram per hour. The gel, which we have been using for years, it is a 1 to 2 milligram gel. Then the intravaginal tablets, PGE2 suppository, intracervical gel, which is Pripidil, which releases 0.5 milligram of the gel per hour. So prostaglandin E2 is available as intravaginal gel and tablets in suppositories, and the Pripidil gel, which Madam Bakshi will be talking about it in details. The last method of cervical ripening is age-old oxytocin, which nowadays we are not using it for induction of labor. It is more used for acceleration of labor. Oxytocin is a peptide hormone which is synthesized in the hypothalamus, released from the posterior pituitary. We know that it directly binds to the oxytocin receptors in the myometrium, and it actually causes myometrial contractility. And it indirectly increases the release of prostaglandin. It has a short life of 3 to 6 minutes, and it reaches a peak level within 40 minutes. Oxytocin is primarily used for labor augmentation. Initially, when no other agents were available, it was being used for induction of labor. So the guideline recommendation for the use of oxytocin, more for acceleration of labor. There is no consensus on the optimal initial dose, dosing interval, and maximum dose. Oxytocin was associated with a higher rate of unsuccessful vaginal delivery. That is why we have stopped using it as a method for induction of labor.
That's it.
Yeah. So in the end, I say must conclude the session by saying that after the coming up of prostaglandins E2, the scene of induction of labor has changed a lot, and now we are able to gain more and more vaginal deliveries because of the availability of prostaglandin E2.
Nina, very nice presentation, and you have specified everything, the use of mechanical devices and the pharmacological agents. What is your experience with misoprostol tablets? And are you using vaginal or oral if you have ever used it?
Actually, misoprostol tablet is not my choice of induction of labor, because I have seen practically that sometimes there is so much of hyperstimulation and lot of fetal distress we have seen with tablets. So my opinion is prostaglandin E2, the gel or the long-acting form, it actually mimics like a normal labor. Dilatation and the effacement happens in a very natural way. So misoprostol sometimes can be very, it acts very fast.
But Nina, the thing is that you are very fortunate. You work in a five-star hospital where it is easy to get the gel and the inserts. But if we talk about the overall scenario, then I think that still there is role of misoprostol vaginal tablets. And the experience that we have had is probably 10 years ago when we used it. But have you used it recently? Because recently the dose prescribed has been very low. And
Yeah,
now,
it is 25 now.
yeah.
Initially
those
they
25
started, yeah.
Yeah, and those tablets are available.
Yes,
So,
now the 25 milligram are available, and then we have found that the hypercontractility is now less.
yeah. So at least in the situations where you cannot afford, then maybe still it does have a role. But
Yeah.
I do agree about the tachysystole part, and we all have burnt our fingers in
Yes.
the beginning of practice when we used to break the tablets and insert a
And we
little.
were not sure what dose we were giving actually.
Yeah, but maybe.
I've heard people saying using mifepristone before giving misoprostol for induction for ripening. So
Yes.
do we use
The-
it, or because I have never seen or
No,
used
no,
it? So
no. And
not,
actually, a lot of studies are also not available on this method of
yeah,
induction.
exactly. But
Yeah,
so,
but there are some
People are
institutes, they
giving,
are
yeah.
using
Yeah.
mifepristone to ripen the cervix, and then they use misoprostol, and they are saying that the results are good.
Yes.
So it's not that we can just discard this, because it does have a role, and if used wisely and in particular situations, still it has a role. And many government institutes, and where affordability is a big problem, again people are using misoprostol.
And of course, to add, Ashadi, for mid-trimester abortion, misoprostol is
That's the
wonderful.
best. That's wonderful.
do we, I have never used, but do we use mechanical dilators if the patient is not already dilated by 39 weeks?
No, not
I've
now.
never used. I've never
We have
used.
never
but in
used, that's why I'm
US,
asking.
It
I've
was
never
all 3-4
US,
decades back.
US they use.
these and laminaria tents, I have never seen in
Yeah.
last 10
It
years.
was,
But
we
in
have
US
seen
they
when we
use
were
it a lot.
students actually.
Yeah, yeah.
There are still people using it.
But like I've worked in England for so many years, and there I was fortunate that those days vaginal gel was available. So there they don't use cervical gel, they use vaginal gel. Why? Because the cervical gel has to be inserted by the doctor, gynecologist, but vaginal gel can be used by the midwives.
Midwife.
So there they used, means first dose had to be by us. So we would go do the Bishop scoring, and the second dose could be inserted by the midwife. She would do the Bishop scoring, tell us what is the score, and accordingly we will advise. So that was the reason they were using vaginal gel, which was more easy to administer. But in India, we all are we all have a very vast experience of using cervical gel.
But
So-
I think, like you said, because of the different hospital settings, like our patients are affordable, the inserts work excellently even when the
Excellent.
Bishop score is not good. But yes, so we had like we did not have such good results when we were using gel in the patients with poor Bishop score. So I was asking about that time, that did we use any mechanical, or did we do anything for improving the Bishop before inducing?
No, means I don't have any experience of using mechanical dilators, and I don't have experience of using mifepristone. But these are the things that some countries, and some countries still they are being used.
Yeah.
So that's excellent. So basically, if I have understood the situation, I'm not a gynecologist. Misoprostol is still a good option for the non-affording population,
Yes.
where affordability is a criteria. And dinoproston would be preferable if affordability is not in need.
Definitely.
Well, would that be
Because
right summarization?
Dr. Neena works in corporate where usually there isn't a problem. Dr. Sonam is a
Right.
phase 3 obstetrician of Indore, so for her also there is no problem. But means this is not the situation with everyone.
That was
No,
my point,
absolutely.
that everybody
We have
cannot
to-
use inserts. Still, there are nursing homes and
Right.
hospitals where gynecologists are still not preferring the inserts because of the costing part.
Yes.
So I think the need of the hour is to have a reasonably well specified options for the different scenarios,
Yes.
where affordability and the clinical picture both are taken into account, and certain things, maybe
Yes.
an Indian guideline over a period of time, let's see. Okay, if there are no other questions, we'll move on to the main, the final lecture. Before that, I will hijack this forum once again for my pleasure and privilege in introducing, I mean, a person who doesn't need any introduction, but still, formality is a formality. So we have been through this expert, and now we move on to the final expert, and I have a special name for her. With due apologies, ma'am, I'm going to refer to you as the 3G expert. And the 3G stands for the great grandmaster of gynecology and obstetrics. So, because of all your achievements and everything. So, Dr. Asha Bakshi, as we all know, she's the lead consultant in Dr. Asha Bakshi Fertility Center in association with Motherhood Hospital in Indore. And to her credit, her current positions are numerous: Secretary ISR, Member Executive Committee, AICC, COG, West Zone, Founder Chairman, and Member Advisory Committee. And just look at the list of awards that her experience and clinical expertise has found their way into her home. To her credit, the first ICSI of MP, first PESA and KC ICI of MP, Padma Shri.
No, I'm not Padma Shri. I think there's some
Master
mistake, some typing mistake over there. It's not, I'm not Padma Shri.
Oh, okay. Okay. Let's say I'm trying to look into the future. Someday. So anyway, a whole list of awards, and past positions are also equally commendable: chairperson, member, president, vice president of various committees, and the number of conferences she has organized is also phenomenal. I will not get into her other experience and academic things, otherwise that will be a lecture to itself. So, ma'am, thank you for being here, and thank you for what you are going to tell us about this new product, Soundin, and your experience. Over to you. I will stop sharing.
Okay, so I will share my screen now. Okay. Okay. So a very good evening to all of you, and I bring greetings from Indore Motherhood Hospital. And I'm going to talk about this excellent product. It's my favorite product, and that's Dinoprostol vaginal insert. And I'll be discussing few things, how the product is and everything, and comparing it with various devices. And one thing I would like to tell you that in the past, when we used to practice, then all of a sudden we used to have fetal distress. All of a sudden we severe uterine contractions, and already I have inserted cervical gel, or already I have given her misoprostol, and then how to remove when you feel so helpless, and immediately you have to shift the patient to the OT. Within 10-20 minutes, you should do cesarean. And I always used to find that what should we do? Should we give a vaginal douche, do something and remove this so that this at least, or people used to say give her NTG and give that to prevent that tetanic contraction. And I think almost 15 years ago, when I saw this advertisement in one of the British Journal of Obs and Gynae, where they had given an advertisement of a tampoon-like thing, which delivers dinoprostone. And the best thing is that you can remove it, and within no time, the side effects, the adverse effects will go away. And I was so pleased. Oh my God, I wish I'm able to use this in India. And then I think almost 10 or 12 years ago, this product was launched in India, and I was one of the very first ones to use it, and was really excited to use it. So let's talk about this product, and that is Dinoprostone vaginal insert, and it is a very good product for cervical ripening. So the indications are initiation or continued cervical ripening in patients at or near term in whom there is a medical indication for induction of labor, and it contains 10 milligram PGE2, and the release is 0.3 milligram per hour, and it is a controlled release, and the half-life is only 1 to 3 minutes. So that's the beauty. Once you remove the device, within 1 to 3 minutes, the action will go. And storage is in freezer in original container. And I would like to really, really warn you all that whenever you get the product, when the midwife gives you the device that yes, you put in, make sure that it comes from the freezer. Because if they don't do, initially in our practice, they didn't understand it has to be in freezer. And from freezer, they'll take it out, leave it, and then it is not effective. And many times this cold chain is not maintained well. And if it is not so, then your device is not going to work. And I've had few cases where for at least 8-10 cases, the induction was not happening. And then I realized that there was a break in cold chain. So very, very important that make sure that it immediately comes out of the freezer. And if you really want this device to be successful, then
sorry to interrupt you, ma'am.
Yeah.
Sorry to interrupt you, ma'am. Ma'am,
Yeah.
can we just wait for the presentation to come on? The presentation is not showing.
Is it? Okay. I'll go back
Yeah.
again. Is it showing now?
No.
Okay, one minute.
Shall I ask Nilesh to project it?
I will again do it.
Okay, sure.
Can you see the screen?
No.
Screen भी नहीं आ रहा है.
No, not yet.
अब आया?
I think अभी आने वाला है. हाँ, अब आया. Yes.
आ गया.
It's there
Okay,
now.
okay, okay. चलो तो मैंने काफी सारा ऐसे ही बोल दिया. It's okay.
No, but it was quite understandable. I mean, that's fine. You were very clear. We can continue from there.
Yeah.
In fact, if you can just go back 2 slides, that would be wonderful.
This is where I was when I was talking. So I was mainly stuck at this slide
2
only.
slides earlier.
Yeah. So I think this freezer thing is very, very important. So if you really want your product to be really successful, your induction to be successful, then make sure that it comes out of the freezer. Then it is a basically controlled release intravaginal insert, and 10 milligram is dispersed in hydrogel mix. It is very simple to insert and to start the treatment. A single insert delivers the controlled release for almost up to 24 hours. And there is a long tape which allows the system to be removed easily. So with a half-life of 1 to 3 minutes, I've already mentioned that removal and avoidance of the adverse effects is very good. So it basically the release is very, very smooth, and rarely ever the patient will complain of severe pain after the insertion. And the continuous release means 0.3 milligram per hour. So total will be 7 milligram PGE2 is released within 24 hours once you insert, and it contains 10 milligram. And administration is very easy. You open the pack, and then this device, you put it in between your index finger and your middle finger, and then gently take it to the posterior fornix, and make sure that you go up to the posterior fornix and position it properly in the transverse manner, and then come out slowly, come out very gently. Make sure that the device remains in the posterior fornix, and only a small portion of the tail comes out, because if it is very long, then when patient goes to toilet or anything, then it will come out easily. So you have to make sure that the tail that is coming out of the introitus is really small. And in the initial practice, when people were not so used to, what I used to ask them that put the whole device inside. At the most, what we will do is we will insert the finger and remove it. So unless you are very confident, then either you put the whole thing with the tail. It is easy to take out the tail even from the vagina, but make sure that the portion which is coming out is very, very small. Then it offers a simple removal in a single step, as you can watch in the video, that just you pull the device and the device is coming out easily. And one important thing which I would like to tell is that if you want to give Syntocinon drip also, because this is what you do after 24 hours, if the patient has not progressed, then you would like to, there is already ripening of the cervix, so you would like to augment the labor with the help of Syntocinon. So, but at least wait for 30 minutes before starting the Syntocinon drip. And indications for removal are if it is already 24 hours, if there is onset of labor, or there is uterine hyperstimulation, rupture of membranes. Very important to inform the midwife and the doctor on duty that whenever there is leaking, then immediately remove the device, because sometimes that can lead to tonic hyperstimulation. So that's very important. If there are any maternal adverse effects, or if there is fetal distress, then in all these situations you have to remove the device. And one more thing I would like to say is that whenever you put this device, do not start another method of induction at the same time. And another method is Syntocinon, because I know of few clinicians who insert the device, they don't have patience, so within 6 hours they will start Syntocinon also. And I know about few medical legal cases that have occurred, and obstetricians are in trouble now, because if the books, they mention that you have to use one device. If you have used device, then do not start Syntocinon drip at the same time. So be very cautious about it. If at all you have to start Syntocinon, remove the device first and then start the Syntocinon drip. Now, comparing this device versus placebo, so naturally we know that it is a device which has got good efficiency, and in RCTs, it has been shown that majority of the women, the cervical ripening happened, and the treatment success was defined as Bishop score more than 3 to 6 within 12 hours, or active labor or vaginal delivery within 12 hours. And these studies were not designed to the power to show differences in cesarean section. But of course, they did show that the dilatation was quite good in primary as well as in multiparous patients. Then ripening of the cervix in majority of the women, it occurred in within 24 hours, and especially in multi, it was even much faster. And in most of the cases, it was found that the cervical ripening had occurred up to 21 hours. So from 12 to 24 hours in the primary and nulliparous women, and within 12 to 24, even in, it was much better in multi. Within 12 hours, almost 50% patients had cervical ripening. Now, it significantly reduces median time to onset of labor as compared to placebo. then it induces labor in majority of the women within 24 hours. And best results you get in patients who are multi. And other thing is when you are more towards the term. So if you have induced somebody to at 39 weeks, then these are the patients where the onset of action will be very fast. So most of my patients in whom I use the insert at 39 weeks or plus, then almost I think 50% or more than 50% patients go in labor within 12 hours only. So then coming to median time to delivery compared with placebo, naturally median time to delivery is much faster with DVI, and we all know that prolonged labor is associated with higher rates of infection, greater use of antibiotic, more maternal distress, increased use of oxytocin, and greater demands on staff and hospital resources, and it can result in a negative birth experience for women. And these days, it's very, very important that the labor is enjoyed by the patient. Labor is like a physiological process. It is a social event as well. So this is an enjoyable experience. And if the patient has been in prolonged labor with exhaustion, helplessness, and increased dependence on nurses, midwives, and support givers, then that's not a good experience. So our aim these days is patients want delivery in boutique hospitals. Why? Because they want to enjoy this experience. So how can that be made comfortable is by using such type of devices. And the reduced duration of labor may therefore contribute to positive childbirth experience, and particularly for the first-time mothers. I think even for second-time mother, every experience has to be a very positive experience. Then it induces labor with one application. So you don't have to, like if you have used gel, then again you have to do vaginal examination, do a repeat gel, again but here, or you have given misoprostol, again you have to repeat. But here, once you have inserted the device, then for 24 hours, you don't have to unnecessarily interfere. Then comparing the mechanical methods, most of the mechanical methods these days are out. Dr. Neena has so nicely demonstrated all the devices and mechanical devices. The only mechanical method in my eyes today is sweeping. Still, I am a great fan of sweeping, and I think it's a very good way of natural induction of labor. So I think this is acceptable even in today's scenario. And another is amniotomy. If the cervix is well dilated and patient is already in labor, then amniotomy we use. But otherwise, Foley's catheter and most of us do not use. And now comparing DVI with Foley's catheter, there is comparative delivery rate, and but there is lower rate of oxytocin augmentation as compared with Foley's catheter, and shorter time to delivery as compared to Foley's catheter, and cesarean rates are comparable in both the situations. Then again, comparable rates of vaginal delivery within 24 hours. So other mechanical methods like double balloon catheter, and here again, one study that demonstrated comparable cesarean section rates, and but they said that DVI results in reduced requirement of oxytocin. So that's a definite advantage of insert compared to oxytocin. Then comparable delivery rates. Then DVI results in reduced requirement for oxytocin. Then comparable cesarean rates. So now other prostaglandins, and what are the other prostaglandins? That is the gel, PGE2 gel, and misoprostol. So coming to PGE2 gel, again, there are improved rate of vaginal delivery within 24 hours compared to gel with DVI, and comparable cesarean section rate. Coming to oral misoprostol, again, lower vaginal delivery with oral misoprostol. DVI results in lower vaginal delivery rate. So here they have shown that oral misoprostol is associated with better vaginal delivery rate. So here oral misoprostol is better as compared to the insert. Then DVI and oral misoprostol result in similar times for the first treatment to vaginal purge, so they are comparable. So, and DVI results in higher vaginal delivery rate within 12 hours compared to oral misoprostol. So that's an advantage. Now coming to safety complications, the biggest complication of induction of labor is uterine hyperstimulation, the tetanic contraction of the uterus. And sometimes you feel that as if the fetus has been actively retained in the uterus. So uterine hyperstimulation is overactivity of the uterus. And this tachysystole, when more than 5 contractions in 10 minutes are there, averaged over a 30 minutes window. And uterine hypersystole or hypertonicity, contraction lasting for more than 2 minutes. So these two things are there. One is uterine tachysystole, another thing is uterine hypersystole. And these two things we usually do not like, we fear this thing, and it may or may not be associated with FHR changes in the fetal heart rate. But most of the times you do see that there are some abnormalities in your CTG, and increased risk of uterine tachysystole is an expected complication associated with oxytocin, dinoprostone, and misoprostol. A deceleration of FHR in response to contractions has been shown to be more indicative of neonatal depression, metabolic acidemia than rate of contraction alone. So you have to take both the things in account. And these are the various FHR categories, and I don't have to teach you all about CTG abnormalities. But the thing is that we have to be, while anytime, whenever you are inducing the labor, then you should have CTG machine, and you should be continuously monitoring these patients. Not just during induction, you don't have to, but when they are in labor, that time you have to monitor. But if you have inserted a vaginal insert, that doesn't mean that all the time you'll keep on monitoring, but yes, at least every 4 to 6 hours you'll take a small tracing and check the heartbeat. Now, preclinical studies have demonstrated a good safety profile of DVI, and it acts locally, has no significant systemic exposure, so less toxicity, and the hydrogel did not show any adverse effect in toxicity studies. It has demonstrated safety profile in all the clinical trials. Hyperstimulation is low, no long-term neonatal complications in clinical trial, and reported APGAR scores of 7 and above were quite good. So it is well tolerated with no incidence of uterine hyperstimulation compared to placebo, and it has comparable results to Foley's catheter, but is associated with higher rates versus double balloon catheter. Then DVI and oral misoprostol, they demonstrate largely favorable safety outcomes. DVI and oral misoprostol demonstrates acceptable safety profile. So at the moment, if we really want to compare, then we should compare oral misoprostol versus DVI. DVI demonstrates a faster resolution of tachysystole following retrieval compared to Mesodel. Then DVI is well tolerated and associated with a lower incidence of tachysystole. So DVI limits pain compared to vaginal PGE2 gel. So if 2 patients are there and one has, and if you take it on visual analog scale of the pain score, then patients with vaginal PGE2 gel seem to be more comfortable. Patients with DVI seem to be at more comfortable zone. And DVI use is associated with lower vaginal examination. And I think this is very important, because that is a nuisance doing vaginal examination. It is so uncomfortable for the patient, and it introduces infection also. And then again, you have to use your staff also economically. So we need things where monitoring becomes less. So in that way, that context also, DVI is better. So overall, when you ask me to conclude, then I would say that DVI is user-friendly with fewer vaginal examinations, less pain and tachysystole, a good safety profile, less fetal distress and FHR abnormalities, high delivery rate within 12 to 24 hours with good cervical ripening, less requirement of oxytocin for augmentation of labor. And the best thing is ease of removal. I would give the highest point if you ask me, then one is ease of removal and second is less vaginal examination, less monitoring. So these are few things about DBI. And but misoprostol also compares quite well, and we have to. I think we can't just get carried away by one method. We have to critically analyze, and there are various situations. You have to take everything in point, and then only you use a method accordingly. So we can't just blindly say that this is the best, but it does have its advantages. So thank you very much for the patient listening, and floor is all for you to ask any questions if you want to.
Wow, that was really great. Thank you so much. That was so crystal clear. We have the two budding gynecologists there.
Budding gynecologist already.
The grandmother gynecologist, mother gynecologist, bacha gynecologist.
Father gynecologist. And father is also gynecologist.
Okay, perfect. Then that's decided. The two of them are gynecologists. Okay.
Yes.
Ma'am, thank you so much. That was really wonderful and the best part was so balanced. So thank you for positioning all the options so appropriately. I had one question, and I was going to ask about the less frequent PV examinations, but in the end, you clarified that in the study also, because that is not only a nuisance but also a source of infection, which
Yes.
can have all kinds of implications.
And it is
One
so
question.
undignified. So many times you have to do the position and all. It is undignified for the patient.
Right. And not to mention the burden on the infrastructure.
Yeah.
I mean, the nursing staff and other people and all
Yeah.
that. This one point about, I mean, I know from regulatory perspective, 24 hours is the cutoff point. But what is so sacrosanct about 24 hours? I mean, if a gynecologist would like to go on for another hour or two, is there any harm? Or that
No,
should
there is no harm
definitely.
because in the beginning only we had said that there were some studies which showed that the maximum, most of the patients benefited by 24 hours. But still few patients, if you leave it for 3-4 hours, I don't see any harm. But means it is not that,
They
oh my
need to be
God.
monitored closely.
Yeah,
Yeah,
but you have to do
absolutely.
good monitoring. But it doesn't matter because it is 10 milligram and you have used only 7.2 milligrams. So still you have the
Right.
aging.
24.
But then again, monitoring is important. And but by chance, if it is at 4 o'clock in the morning and patient is sleeping, then don't wake her up. Ki now it is your time. We have to remove it. You can remove it at 6 o'clock,
Right.
7 o'clock,
Absolutely.
and it is more patient friendly at more friendly hours.
I've heard about some doctors in South. I don't know. We don't practice. They put this insert, like they put insert twice. Like if the cervix has not ripened after 24 hours, they also repeat the insert.
Oh,
So
is that wise?
I'm not
I
sure.
have not
Haven't tried. We
gone through
haven't.
any studies.
Yeah, there are.
Ah.
But even if we do, is it? I don't know.
I don't know. When we used to insert this gel, so the guidelines were that you can maximally insert 3 gels. And after 3 gels, you have to give a break to the patient. Then you can restart after a few days. So this is what I was aware
Okay,
of.
one question about what Dr. Sonam mentioned just now, the use of 2 devices. Now, those 2 devices, is that within the period of 24 hours or is it after 24 hours they put in the
After
second?
24 hours, like we have put the first
Oh.
device for 24 hours, then we remove it, and after some time we insert the other device,
Okay.
insert after 24 hours.
Okay. Well, I guess we'll have to wait for their experience to get published.
Yes.
Yeah.
I think it has to be more in research setting and then to
Right.
use it. Yeah.
Correct. But that's an interesting point. We will certainly keep a watch out for.
Yeah, it would be interesting. It's worth finding out, going through the literature and finding out. Yeah.
Okay. Okay. Another question. I mean, this may be theoretical, but I mean, while reading, I came across a lot of reference to outpatient IOL happening. I'm not talking about the methodology, but the concept of outpatient IOL seems to be picking up in the West a lot. Number one, what is the position in India? And number two, would a device like this, strictly not OPD, we can't send her home, but she can move around, be mobile around the hospital and things. Does that make sense?
Yeah, she is absolutely mobile in the hospital. At the moment, we are a bit hesitant to do it and send it from home. But looking that it does not lead to tachycystole, you can buy few hours. Say you put it in your clinic, do a CTG monitoring, and then send the patient to her home. She can pick up the stuff and then go. So buying few hours is fine.
Right.
But at the moment, I'm a bit hesitant to do induction of labor at home. But maybe time will tell us.
Yeah.
And other people's, and maybe sometimes what will happen is accidentally you'll come to know that, oh, this works well. So we don't know. But
I think we can try this in the low risk pregnancies we induce at 39 weeks for not going in labor. Absolutely low risk with good Dopplers. We had a Doppler in previous couple of days. The CTG is good. So we can insert and send them home and call them in.
And you never know, there are some surprises in obstetrics always. So
at
it is
the moment,
better.
I would be hesitant. At the moment, I would be hesitant. But let's see. Means it is a point to be
And then we have to see whether doing this saves on the cost or something. Then, like, if it is worth doing it, if it doesn't, then maybe we should not.
Especially, I wouldn't do that in the night. Patient will go home. And if something goes wrong.
Yeah.
Then mute kar de, Sonam, mute kar. Mute. If something goes wrong, you don't know. So, medico-legally, sometimes we have seen even in a routine induction, even in hospital, there have been mishaps. So
Yes.
if this mishap happens at home, then how you are going to save yourself from medico-legal problems? So today,
Absolutely.
I think most important is to be medico-legally safe. You don't want any hassles.
Right.
I don't want any hassles. And
Correct,
obstetrics always comes out with surprises, and I wouldn't want any hassle at all.
Absolutely. Absolutely right.
There
Doctor,
is one
yeah.
question is also there, madam. How we can prevent the fall of dinoprostone vaginal insert after inserting it?
It doesn't fall.
It falls, Nina. Sometimes it comes off. So it's very important. Yeah, that wing is only small tail is left outside. Sometimes that big tail is left outside and it comes out. So it has come out.
Practice, we don't put the small thing only. We push the entire thing inside.
Okay, so that is the reason better to put the whole thing in. Then the things will not come out.
It doesn't come out then.
Yeah. Sometimes if the patient is in active labor, and even if it comes out, it's okay, because when that mucus plug and that blood clot and everything comes out, with that sometimes it may come out, so that's fine.
And madam, do patients have to fall asleep for a certain time or in some position to prevent the fallout of that insert?
Yeah.
Like
Insert, it has to be deep in the fornix and it has to be horizontal with
transversely.
It should be transverse. It should not be vertical.
They have to fall asleep for half an hour to prevent the fall of insert.
No,
That's fine. It's not necessary, but it's okay. They can lie down, but it's not necessary. With gel, it was necessary, but with this, it is not necessary.
Okay. And ma'am, gel is used.
But usually what happens after that, you do CTG. So for CTG, anyway, patient is going to be there for 15 to 20 minutes on bed. So that's okay.
And ma'am, gel is used intra-cervical.
Yeah, but in the West, they use it intravaginal also.
So is there any disadvantage of using it in intra-cervical as compared to intravaginal?
Because what happens when you use intravaginal, you can just insert it with a syringe. But if you use intracervical, you have to use a speculum, then you have to insert it into the cervix. So it is more invasive. So these days, people want things to be minimally invasive. Means you don't, it should not require too many, getting one speculum, then putting one. Sometimes you may need an Ellis
Assistant also. You might need an assistant.
Yeah. So all those things have to be very hassle-free.
True, true. So I think this is as close to being a hassle-free device as, I mean, until now, it may
Yeah,
not be the
it is.
perfect device.
Yeah.
And obviously affordability is an issue, but until now it seems to be, in fact, while listening to your and seeing your slides, I realized that I can summarize the whole thing in 4 S's. A, it is simple. So simplicity is one criteria. Second, the speed, the onset of induction of labor.
It's
So
smooth.
obviously it is faster. So speed is another character. The very important thing, safety. I mean, all the side effects that we have been seeing, while they can happen now also, but they are much less. So safety is another S to look for. And the last, maybe I'm wrong, but it seemed surety is another thing, because most of the women would lead to induction of labor according to the clinical trial as compared to the control groups. So surety of induction of labor also becomes a plus point. So I think these 4 S's would they be correct? Safety, simplicity, speed, and surety.
Yes.
Because I mean, I'm just asking from the point of view that if we have to project it to other people, can these be highlights of the product?
Yes,
I mean,
yes.
I agree. It's other
I think
options are also
instead of that surety, you should put ease of removal. Means the biggest
okay,
advantage
yes.
of this is
Yes,
ease of
yes.
removal.
Absolutely. I'll note that down.
I
Yes.
would rather
That's a very important point.
ease of removal, because
Okay, speaking
when
of
I
removal,
first saw it, the best thing that appealed to me was ease of removal.
just a practical question. Speaking of removal, we have inserted the device intravaginally. It is in position. The woman is resting. Now she goes to the bathroom, toilet, and is there an accidental chance of it coming out because of
Less chances unless she's in labor, or unless
Okay.
it has not been put in properly. Otherwise, less
otherwise
chances.
it's not an issue, right?
No.
Okay.
Usually
So
no.
that's another practical point. That's another practical point to keep in mind. Great. I think we have learned a lot from.
How much time it will take to use the IOL in nulliparous woman and in multiparous woman, based on your practice?
Usually
repeat
in
your question?
multiparous woman, labor starts almost before 12 hours. Especially if she is at term and the cervix is favorable. And in nulliparous, it takes time. So we may have to wait
18 to 24 hours usually.
Yeah.
Okay, so less than 12 hours in multiparous and maybe up to 24 hours in nulliparous.
Yes.
Okay, that's still good enough as long as it's safe.
And
okay.
I think the same case for gel. Gel also.
Gel also is quite, means we have had good experience with gel, except that sometimes that tachysystole occurs, and
gel need
multiple insertions and multiple PV examination. But I think we have used gel so successfully for 20 years or so. We have used it, and now also sometimes we use it because of the cost. So
right.
But I feel misoprostol is again something which is coming up, and we have to think about that.
Right.
I think it's time to wind up. I have to reach home.
Yeah. Any other questions, Nilesh?
No.
Okay. So thank you very much, ma'am. Thank you, Dr. Nina. Thank you
so much.
Thank you.
Dr. Sonam, I think, is taking care of the budding gynecologist.
Yeah, because I'm also here, no? So it's high time children need.
I've been listening, but I think I was.
Okay. thank you very much for your very crisp presentation, Dr. Sonam. And I will put together all this in as simple and short a form and send it to all of you. And if you want to make any modifications, feel free, and then we will. And we would also like to do some real world evidence studies. No
Yes.
intervention, no protocol, entirely your way of doing it. But if you can devote some time, we will also help you. We would
Dr.
like to
Nina
make some
has equally
publications out of it.
used this device very often. She has a
Yes.
very good experience of
And
using
we
this
are
device.
actually comparing the gel with insert and mesoprost at our hospital. We are making
Perfect.
the data.
Okay, well, that's great. We look forward to that, ma'am. Thank you so much.
Sure. Okay.
Okay,
Bye.
thank you
Bye.
everyone
Bye.
for
Thanks
joining
for-
in.
Thank you
Good
so
night.
much for your invaluable
Night.
Have a good evening. Bye. Bye, Nilesh.
Bye.
Bye.